Hi, my name is Elena, and today I'm going to be talking about mechanical ventilation, weaning, and transition to BiPAP after a weaning. So, for our management plan for Mr. Smith, I just wanted to kind of show you what a normal ABG looks like. So, our pH level for a normal adult is 7.35 to 7.45. A CO2 is anywhere between 35 to 45, and our bicarb is anywhere between 22 to 26. For our COPD patients, their APGs are a little bit different just because they function with a higher CO2 levels. So for them, their CO2 levels are between 55 to 65, making their pH a little bit lower. So theirs will stay anywhere between 7.35 to 7.38. And then their bicarb is also a little bit higher, which is 26 to 30. Their numbers just kind of vary a little bit just because of how much CO2 that they function with in their bodies. Mr. Smith is a COPD patient, so he functions on a CO2 drive, um, which means his body's just used to retaining that CO2. And if we blow off and put him like on a BiPAP or even on the ventilator, we have to be very careful to not blow off a lot of CO2 just because COPD patients become obtunded and then we knock out their respiratory drive. And we don't want to do that. Like, we want to be able to extubate Mr. Smith and be able to have him be able to breathe on his own. So knocking that CO2 drive is not what we want to do. So we have to proceed with caution, so that he is able to successfully. Mr. Smith's ventilator setting. So he is on a mode of volume control SIMV. His set total volume is 450. His rate is 10 breaths per minute. His spontaneous tidal volume is 250. So that is what he is pulling on his own. Um, his total rate is 13 breaths per minute. So he is breathing a little over than his set rate. So he's breathing 3 breaths extra. His pressure support is 5 centimeters of water. His PEEP is also 5 centimeters of water, and he is on an FiO2 of 35. Precautions for weaning and patient's hemodynamics. So precautions for weaning, we definitely try to keep those very, very accurate and very, very consistent, just because those precautions can either mean a failed um, extubation or spontaneous breathing trial or a successful one. So for precautions, we follow the SBT, which is the spontaneous breathing trial protocol of 30 to 120 minutes. We try not to keep a patient for longer than that, just because if you go over 120 minutes, you wear them out, and then most likely they will fail because they tire out. And then an SBT is normally used using a T-piece or a low-level pressure support with PEEP, as recommended, depending on what the physician orders. Um, Once again, we definitely try to avoid over testing. So one spontaneous breathing trial a day to prevent exhaustion. Cuff leak test. We perform cuff leak tests to ensure absence of laryngeal edema, just to make sure that they are able to keep their airway patent and fully functioning. If there is edema and swelling, then most likely that'll close up, which will probably cause them to go into respiratory distress, and then we will have to reintubate. When to stop weaning trials. So to stop, parameters to stop is if the respiratory rate is greater than 35 breaths per minute, if their SpO2 is anywhere between or under 88 to 90%, if their heart rate changes of greater than 20% from baseline, or signs of increased work of breathing, such as use of accessory muscles, or their mental status deteriorates. So for hemodynamics range during a weaning process, we try to keep their heart rate anywhere between 60 to 100 beats per minute. Their RSBI should be higher than 105. The respiratory rate under 35 breaths per minute. SpO2 anywhere between 90 to 92. And their blood pressure, we try to keep it as normal as 120 over 80. For ventilator Ventilator criteria: the PEEP greater than or equal to 5 to 8 centimeters of water, FiO2 less than or equal to 40, and Mr. Smith is on a 35 FiO2. pH greater than or equal to 7.25, and then their minute ventilation greater than or equal to 12 to 15 liters per minute. Initiating weaning. Mr. Smith is hemodynamically stable with the SpO2 of 91%. The physician, Dr. Knows, has placed an order to put Mr. Smith on minimal mechanical values, and he wants a SIMV with a rate of 4. So to confirm readiness for this initiation, once again, we have to make sure that his respiratory rate is anywhere between 25 to 30. And currently right now he's at a 13 because he is breathing a little over his normal 10. His tidal volume has to be greater than or equal to 5 milliliters per kilograms of ideal body weight. His RSBI has to be greater than 105. His SpO2 has to be greater than or equal to 90 on an FiO2 of less than 40. So Mr. Smith has an SpO2 of 91 and he is on 35% of FiO2. So he qualifies for this initiating weaning. And then he is hemodynamically stable. So first adjustments to place Mr. Smith on a rate of 4. So first we will make the first changes to his respiratory rate to go from a rate of 10 that he is on, and we will go down by 2. So we'll go from 10 to 8 to 6 to 4 with increments of 15 to 30 minutes in between each change to make sure that his hemodynamics don't change and that he is able to tolerate it. If he is unable to tolerate, then we will completely stop. But as we work down, it'll be 15 to 30 minutes between each change. Once again, during and between those changes, we will assess respiratory rate, tidal volume, his heart rate, his blood pressure, SpO2, and work of breathing. And then as adjustments continue, his pressure support will be adjusted to allow spontaneous breathing to take over. Mr. Smith has a pressure support of 5 centimeters of water, but it can be adjusted to 10 centimeters of water just to be able to help him overcome that resistance in the ET tube, just because it is going to start lowering his respiratory rate. His minute ventilation has to be monitored as the rate is dropped. Minute ventilation will also have to be anywhere between 5 to 10 milliliters per minute. And then as long as his EtCO2 and his exhaled CO2 and his PaCO2 maintained stable, he is allowed to continue with the weaning process.